All right. Well, now we're going to move to our opening plenary, which is being led by Health Management Director Juan Montañez. I was trying to do it correctly. Did I do it right? No. Perfect. Okay, great. I said it like 25 times in my head. And then, okay, so we are going to start the opening plenary. It's about scaling AI adoption across the healthcare ecosystem. So please help me welcome that group to the stage.
Buenos dias, good morning. I was tempted to do this in Spanish like Bad Bunny did the Super Bowl concert, but no, it'll be in English, I promise, it'll be in English. Anyhow, so I am pleased to be facilitating this panel. It is not typical that we actually have one of these events kick off with a technology session, but this is not going to be a nerdy, dorky session. We have people here that can speak to the power of technology and how it can truly be transformational, and we do believe that artificial intelligence is that technology. So we have assembled a powerhouse panel, folks that have fully the expertise that will make for a very interesting conversation. So we'll start with Professor, they don't like to be called that, but they are professors, so we should acknowledge that. So Jeff Skolnick at Georgia Tech. I'm a yellow jacket, so is Jason, so is John, so is, and Patty's daughter is a tech graduate too, so you know, we have purposely loaded the panel with yellow jackets. Jeff has done a lot more than what shows up on the slide here. He actually has some biotech ventures that he'll be talking about too. But he is an emeritus professor in the field of biology at Georgia Tech. Patty, whom I've known for 30 years now, how about that? We started at the same health system in Atlanta back then, former driving buddy as well. She has been the CIO of 4 health systems across the state of Georgia, and now she runs a consulting practice designed to help health systems make smart choices on who they have as CIOs, and smart choices in terms of technology. Jason, I've known for even longer, 32 years. I know we're dating people here. He was a summer intern at the same hospital where I started working back in 1994. And since then, he's done everything you can think of in healthcare. He has been the head of the HHS branch at OPB. He worked with me at the Department of Community Health and was director of analytics there. He ran a CSB. He was a VP at Deakin, and most recently he ran one of the Georgia Medicaid plans. In fact, he was a regional vice president for that same insurance company. So he can tell you anything you need to know about how healthcare works or doesn't work in the great state of Georgia. And of course, the yellow jacket. Then we get to Kwame. So how many people do you know who are an attorney, a nurse, and have Serena Williams' cell phone number on speed dial? Well, that's Kwame for you right there. He is the founder and CEO of ThriveLink, a company that leverages AI to empower consumers when it comes to navigating health and human services benefits, and he'll tell you about his journey with AI. And then last but certainly not least, Professor John Duke, a physician who's also a researcher at GTRI, who runs Georgia's all-payer claims database. By the way, gotta brag about this, Georgia Tech gets the second most federal research funding in the country. I'll tell you which one is number one, but eventually we'll get to number one too, so congratulations. Again, Georgia Tech is just killing it. I love it. So I'll get out of the way of the presenters in a bit, but I just want to give you a little bit of backdrop and start by stating what I think you already know, which is that we have been living in the world of AI for a while. It's the generative AI which we have been experiencing most recently, that's truly potentially transformational. But if you think about how power plants or just any kind of factory operates, they've been using AI for a long time. Airlines, if it weren't for AI, they would collapse. In fact, when their systems fail, you know what happens. We have long lines at airports and end up sleeping in airports for 3 days. We all have AI in our phones in different forms, Siri being a good example of that. I was very impressed to see that Atlanta is chock full of Waymos, and Waymos wouldn't function without AI, and I still don't get it in. Call me a Luddite if you want, but I'm not there. But what is really getting people's attention is how generative AI is being used to do things that nobody thought possible, including seeing Brad Pitt and Tom Cruise fight in a movie that doesn't exist. It was all purely created in AI. And now there is an even bigger push to get AI even in classrooms. So this image is from a meeting held at the White House a couple of weeks ago. No jokes. I'm tempted, but I won't. About a robot that is being proposed to be the first iteration of a teacher. So now we're talking about potentially having robots teach kids in classrooms. But there's actually a global effort. There were multiple first ladies that attended this event. And it's the kind of thing that gets people both awed, incredulous, and fearful about how AI can impact our lives, potentially take jobs away. Yes, you have the people that think that this is the beginnings of HAL 9000 or Silence or Skynet, but it all comes down to really figuring out, trying to get ahead. This is one of those technologies that's gotten ahead of our ability, I would argue, to manage it. So now it's a question of how do we take a step back, not overreact, but really have thoughtful conversations about how AI can truly be deployed in an effective way to transform. It can transform any industry. In the case of healthcare, we think it definitely has tremendous transformational potential. We've invested tens of billions of dollars over the last 30 years in technology, and I don't think anybody would think that we're actually getting tens of billions of dollars worth of ROI out of it. AI can truly be that one technology that you can get incredible ROI out of, and it can truly transform how consumers operate within the healthcare system. It can transform how providers deliver and manage care. It can change how health plans interact with providers and consumers, and it can even help with the regulation of healthcare. So without further ado, the session agenda. We're going to ask our panelists, and they've been given the unenviable task to speak for like 7 or 8 minutes, but they talk fast, to touch on how they're adopting AI and promoting its use, how AI is being adopted within the components of the health system that they have visibility into, impactful AI use cases that they're particularly passionate about, what they might see as adoption barriers to AI, and how those barriers can be removed. And again, the goal is to talk not so much about point use cases, if you will, but big picture. Population health management, life sciences, changing how providers diagnose and treat, changing the operations of providers and health plans, and then empowerment, really giving consumers the tools that they can use to really be better consumers of healthcare. So with that as the premise, and it's a big premise, we're going to start out with Dr. Skolnick, and I'm happy to be the clicker person, if that's all right. Or I can see the clicker if you tell me.
Okay, thank you very much. Okay, I'm going to try to do roughly a bunch of things in a relatively short period of time. And so it's kind of like AI, it's staring at the sun. Hopefully you'll get some ideas. So first of all, one of the questions is that, I'm a computational biologist, so we start from the bottom up. And the question, amongst the things you may be thinking of is, you want to fix a disease. One of the questions is, how can AI tell us what actually is driving the disease? Now you have a phenotype, purple toe. There may be hundreds of molecular mechanisms that give you purple toe, some of which may kill you, and some of which actually are very benign. So how do you go from the disease to figuring out what are the targets to fix the disease, to developing a targeted therapy for you, not for me? I mean, you know, for example, a lot of your warfarin therapy. Warfarin is given, you want to keep blood clots, except 8% of people can't clot because they don't have the enzyme to actually metabolize warfarin. So you want to worry about the person's genetics. But one of the things you have to understand is, and this is really important, is most diseases don't occur independent of each other. Diseases tend to be comorbid. And this is actually related to the interrelationship with the drivers of the disease. So you can imagine trying to construct a tree of life for diseases. A precedes B, which precedes C. If you can get A, you'll often say, if I get cancer early enough, survival rates are great. If I get it late enough, life is not so great. Actually, can we use AI to mine medical records to tell us what are the earliest succession of diseases, and then how do we fix them and intervene early? It's what I call the Monjaro effect, right? You lose weight, all of a sudden, cancer, obesity, diabetes has been reduced. A simple treatment, well, relatively simple early, okay, from saliva spit of a Gila monster in the beginning, to actually doing it. So how can you go from the beginning to the end? And so I'm going to go through briefly, how you go about doing this. So one of the questions is, you got to figure out, AI can help tell you what are the drivers of the disease. Unless you think this is an irrelevant question, half the drugs that don't kill you, when you test them, fail efficacy. Guess what? You picked the wrong target or targets for the disease. So you've got some of the symptomatology, but you get it wrong. So if you want to have more shots on goal, you better know what for the particular population variant can AI help us fix the disease. Then you want to say, okay, what are the proteins that drive the disease? What are the proteins that I want to fix for the disease? Now, there's easy diseases and hard diseases, and a lot of them are actually not tricky to the easy ones. The easy ones are so-called Mendelian diseases. These are single gene diseases. I was talking to a gentleman about sickle cell anemia, right? And there's about 7,000 rare diseases lurking around, a lot of which have no treatments and are mostly Mendelian, but even there it gets confusing because if you have a bunch of amino acid mutations, which is the ones that will kill you and which are the ones that are enough? AI can help you do that. Then you want to go, okay, I've got a target, a set of targets, and actually most complex diseases are caused by more than the malfunctioning of one protein, so it's kind of a swarm effect. This is where AI can play really an important role because it can deal with collections of information. You can juggle one ball, two balls. I don't know anybody here, the best athletes who can juggle 20,000 balls. And that's the problem we're trying to face. One of the things you can do is if you can do the Viagra effect. Now remember, Viagra is a blood pressure med. And late middle-aged men, when asked to give it back, says, nope, I'm not giving it back. This turns out that a lot of drugs, because of the nature of how proteins work, can be repurposed because they have similar binding motifs, even though the clinical efficacy is different. Repurposed drugs, and your endogenous metabolites, the vitamins and stuff in you, of which there's about 250,000, can be used, and the advantage of this is you know what the toxicity is. So if you want to fix somebody who's dying today, you obviously want to develop new drugs, but on the other hand, if you need to do it now, it's much easier to do repurposed drugs. Can you suggest what are drugs that fix the disease? And here AI can play. Now, this is great. I can do this for puree of human. I took all of us, I ground this up. It's just like it's so-called metagenomics. This is you study a batch of seawater. I don't know who the organism is, puree of human, population race. That's great. Except you want to know for you. Okay. You want to know for this patient, can AI tell me what are your particular drivers? And this is what GeneHealth.AI, actually, the company I'm co-founder, Ray Briscoe, is trying to do. Figure it out. Now, you've done all this. That's on a molecular level. This is where I spend most of my days toiling and pushing rocks up the hill and trying not to get crushed. But you can also, there's a tremendous amount of medical records. There's gold in them dar hills, okay? And now let me tell you a story. Okay. If you look at disease progressions in the All of Us database, that AI now and generative AI can do, because you can mine this thing, and you can calculate statistically what is the probability. It turns out that if a woman has her ovaries out, often they'll do an oophorectomy and they'll yank, her uterus, they'll yank the ovaries and her fallopian tubes, because you'll have a 1 in 70 chance of developing ovarian cancer, typically diagnosed stage 4. Not exactly a good day at the beach. Survival rates are less than 10% after 5 years. However, if you actually study the medical records, and this is where this actually has implications, if a woman develops sleep apnea as a result of her hormonal imbalances, because, I'm not a female, so this is only by inference, so bear with me, ladies. You go into premature menopause. Premature menopause, amongst the symptoms, is sleep apnea, because your hormones are screwed up. If you have your ovaries out, sleep apnea, do you know what the odds ratio of developing dementia is relative to the general population? 12.5 times. So now I ask you, the logically equivalent thing to remove the chance of developing ovarian cancer, where it's to yank it out while you're doing a hysterectomy, well, maybe you want to reconsider this under certain conditions. So this is an example by studying medical records and looking at disease progressions. It can change clinical outcomes dramatically. Now, we're in the very early stages of this, and these things don't work perfectly. Anybody who tells you AI is going to solve every problem yesterday, no. It's a prioritization tool of look here, not there. But what it can do is by looking at disease trajectories, and this is some work we're doing now. If I can figure out for you, based on your genomic sequences, the viruses and the bacteria you're associated with, and if you ever doubt that viruses and bacteria affect clinical outcome codes, okay? So you need to know as much information as possible, and this is a plea to do that. Medical records are incredibly valuable. If I get disease A, it's like I'm sitting in the kitchen and there's a little kitchen fire, so I pour a little bit of water, I put out the fire. You let the disease go to disease C, which is glioblastoma, the water isn't going to help. You're going to die. Okay. So early intervention by using repurposed drugs and/or treatments can stop downstream progression, and that's the idea that we're trying to pursue. We try to revolutionize, or at least attempt to move the needle for healthcare and understand how these things work. And there's a lot of plumbing behind this, but that's what we're trying to do. And so I'm going to leave you with a question. I mean, in a lot of these talks, they're very interesting and they're very informative. But what can we as a community do? And this is a community effort. I mean, I'm just a little piece of a very complicated thing, a gnat on the back of an elephant. What can we do to uniformly get together to have Georgia lead the application of AI for transformative healthcare, putting all the pieces together? And there's a lot of pieces of which I have zero expertise, but all of you do. Perhaps we can create a pilot project to actually show how AI works and what works, what doesn't. It's kind of like the Wright brothers plane. I mean, when in the beginning it kind of doesn't work great, you go 300 feet, eventually you wind up going around the moon for a quarter, and who knows. You got to start somewhere. And I will just leave you with the thought, there's tremendous promise, there's tremendous hype, but when you cut through the hype, it can really help prioritize and view it as a look here, not there. I have a lot of choices. I want to make the best choices for my patient. So thank you for your time.
Good morning, everyone. I'm now going to talk about sort of what's really happening in our healthcare delivery systems. I did an informal survey of some of my colleagues, and this is across the country, but I think it applies to the state of Georgia, and it also it agrees with what I see in my day-to-day work and what I read about. So. What we looked at is where they are in their AI maturity and what kind of obstacles they're facing. And if the respondents, if I look at the respondents and what their enterprise EHR is, which has a lot to do with where they are in their maturity, half of them are Epic, about 17% are Oracle Health, and about 17% are Meditech. And if I look at those three EHR vendors, Epic really is the leader, not necessarily because they're that innovative, but they have very strong adoption. And they target what their customers ask. They do a lot of process automation, clinician satisfaction tools, and revenue cycle process. Oracle is, I think, probably the most innovative. Unfortunately, Oracle doesn't really have the trust of the marketplace, and so they struggle with adoption. And Meditech typically lags behind, as they are in this case, and they'll come up slowly and follow. They're steady Eddie, but not right now the most innovative. And if we look at the AI maturity side of this, 40% of the respondents have an enterprise-wide AI strategy and governance. I would venture to say that most of them are Epic clients because Epic actually provides a lot of that framework for them. 25% of them have optional deployments, which means typically they have a maybe revenue cycle is using AI, so they have some departments that are using it. And then 35% are really just still testing it out, still dipping their toe in the water and still considering what use cases would be valuable to them. And when we look at the most valued use cases, this is from the CIOs, the top use case is clinical documentation. That is that yellow line. As you can see, it's way out there. Next is imaging diagnostics. That's the purple bar. And it's just over half of the clinical documentation. And then this was surprising to me. The third most valuable use case is revenue cycle. I think revenue cycle is a no-brainer. And it's less than half of clinical documentation. So you can, right now, that's where we're focused. Clinical documentation, which is also clinician satisfaction, imaging diagnostics, also clinician satisfaction and productivity, and then revenue cycle automation, which hopefully is helping with their finances. Next, we'll look at some of the barriers that they're experiencing. I had them rank some barriers, but also let them free text in what they thought were their top 3 barriers. They aligned quite well. If you look at the ranking on the left, vendor hype versus reality.
Can you click again?
Oh, thank you. I thought I did. Oh, thank you. Maybe you should have done the clicker. Vendor hype versus reality, which is a big issue. That is their number one barrier, is does the vendor really have what they say they have? And is it really going to work in my organization? And then budget constraints tied for number 1. That is on the top 3 barriers written in by the CIOs. Number 2, cost and unclear ROI. And then workforce readiness wasn't really, well, it was mentioned, but it was a low scoring barrier from the CIOs. I also think they were talking about IT staff, not necessarily workforce. Regulatory uncertainty, that's the third barrier, and as the CIO described it, security and privacy. So as we all look at healthcare policy, we need to understand that AI has to fit in with all of our policies and regulations for us to be able to use it. So, how do we measure success? I think that there's a lot of opportunity here, but it's not really materializing quite yet. And when I asked the CIOs where they were getting their AI applications, the primary answers were my enterprise EHR or third-party apps. And what's going to happen is they're going to get some baseline products from their enterprise EHR right now. And if they want something very specific to a department or like a pharmacy or a lab, they're probably going to have to buy it from a third party. And there's a small percentage that are doing some in-house development. We may see that grow, but health systems, unless they're academic health systems or the very large Intermountains Mayo Clinics, they typically don't do in-house development. And as of right now, for a financial ROI, 65% of organizations that are using AI have not really seen a financial ROI yet, which there are some other benefits, but financial ROI in the state of healthcare now is very important. What are they using to measure when they select products? Productivity improvements, clinician satisfaction, operational efficiency, followed by financial. So let's recap. We are really right now in what we call in IT a best of breed application portfolio situation. Before we all implemented these enterprise EHRs, that's where we were with basic IT systems for health systems. And we're there again for AI. That's going to evolve over time, and we're going to end up more in an enterprise situation, but I think we're going to be stuck in this best of breed for a while. That is very difficult on the technology side of this, just managing it all. Less than half of the organizations have a mature AI strategy, and there are still significant barriers that remain, and the financial ROI hasn't materialized yet. That doesn't seem very positive, does it? But when I asked them, do you think AI is going to improve healthcare delivery in the next 5 years? They all said absolutely yes. And I'll tell you, CIOs, you all may work with us, we tend to be a little bit on the conservative side when it comes to technology, although we're being pushed now to really look at how we can innovate. But for them to all say yes without question is, I think, pretty significant. And I think that it really says we can make this dream a reality in Georgia. So that is kind of where we are, boots on the ground. Thank you.
Morning, y'all. Good to see everybody. Excited to be in front of friends and I feel like family members. And as Juan said, hopefully you're not going to get too techie from me, but it was funny. Juan was like, hey, get creative. And if you want to use AI to generate your slides for AI, go ahead and do that. So you're going to see some AI generated slides here. And they were a little bit overly techie because I do nerd out even though I'm a systems guy. But as I was thinking over the last weekend kind of about coming to speak today, one of the things you guys might know, right? The last decade, a little over a decade, I've been in the payer space, a couple of managed care companies. It was a great kind of immersion into the world of payer. I've been, in the provider prior to that and public policy at the highest levels. And it was interesting. I said, I need to get on that side to learn it and understand it. And so as I was thinking about the streams of my past career, there's really a confluence, right? I'm a systems guy, an engineering guy that needs to take place that I think AI can help us transform all these disparate systems, payer, provider, policy, community, with Jeff here, with Archie, right? These are all important, a four-legged stool of what we've got to have to transform the system. So over the weekend, as I was thinking about it, I was like, man, some of the hardest, the future, the next couple of months that I'm facing could be the launch of this new company, Confluence Health Strategies, as I've jumped out of managed care to help transform the system. Or it could be preparation for the state of reform, but it was funny. It ended up being up at my cabin up in Ellijay, building this bear box. I don't know if any of you guys up in the mountains, bears everywhere, right? And building that bear box, I started thinking, man, it took me this long, a couple of years, to build a bear box, to keep the bears out of the trash. I mean, they were making my backyard up in the mountains their personal buffet and just making a mess, a landfill up there. Well, it kind of reminded me of our healthcare system, of where we are today, right? We're really a system, and I do need to change the slides here, in kind of a reactive, passive mode, right? All of us in the healthcare continuum and ecosystem, I think that top line process flow will resonate with all of us. One that is, we wait for something acute, catastrophic to happen in many, many cases to serve and intervene on the people, the communities, the families that we care about. And I think getting up ahead instead of incurring the cost over and over and over, like those bears, right, where they're tearing trash, apart my trash cans. Same thing in our medical healthcare environment. We wait till that acute emergent episode often happens before we intervene. Why? Because we're all incented in our different silos, whether that's at the state level, having worked, right? I'm once a DCHer, always a DCHer, right? And I saw that over and over with our child welfare system, working with our Medicaid agency, working with our juvenile justice and our corrections, or in the provider space, running the largest behavioral health IDD shop in the state of Georgia. The lack of connectivity of serving those families to our health systems and our primary care, and onto the payer, right? The payer side where, we're incented by our state regulators to achieve certain outcomes and objectives, but a lot of times we're challenged with connecting systems. And at the root of that comes the data, right? The data that helps us transform the system. AI is great. I'm excited about it. And as an industrial engineer, a systems guy, I do think it holds a lot of promise, a rapid cycle improvement. That's a big reason why I jumped out of kind of the formal payer space to get into the space in between payer, provider, community, and policy. And a lot of the disconnected systems start not just with our own perverse, I'll say, incentives to serve our own objective within our verticals, but the disparate data sources. So you've heard from some of the best and brightest minds already. Worked with Patty over my career from an IT, CIO perspective. And you're going to hear from John from an APCD perspective, all payer claims database. We've got all kind of disparate systems that are disconnected that we've got to connect. And that comes through policy change, law change, and process change from leadership and leadership in this room. And when we get to that place, we're looking at a democratization of data that can overlay with the AI that can be transformative and move us from the passive to the population health intercept model, what I call the population health intercept model, moving upstream to intercept, acute, really expensive cases that lead to poor outcomes and lead to the breakdown of individuals, families, and communities. And, we're here to keep families and communities together. I'm going to hit lightly on the next couple of slides, but this is just a use case as an example of someone that you all might interface with, right? A DeKalb County citizen that you might, from a care coordination perspective, make a quality gap closer check on, or a plan might, or a state official might interface with. I mean, even as a state official, I did case management and care coordination. It's kind of interesting from a policy perspective. And oftentimes when these checks are made, or a routine call is made for a gap closure, there's a lot of information that is shared that maybe a human might not pick up on, right? I've lost my AC today. I wasn't able to pay my utility, my electric bill. I missed, because of that, I didn't feel like getting out. I couldn't go get my meds refilled. And if there are those information sources that we've now collected a very valuable information, if we can connect those and overlay that with ambient AI, the ability for agents to listen in large language models and convert that to kind of actionable, intelligent kind of actions, and then from an agentic perspective, take that information in ambient listening in that telephonic conversation to take agentic action on behalf in that phone call through an agent to say, okay, the agent heard, number one, lost his AC. We know from monitoring population health, it's an extremely hot day over here in DeKalb County. We know he's missed his med refill, and we know he just got discharged from the hospital. He's got a high risk population or risk factor score. An intervention needs to happen. And if that agent, through the ambient listening and the agentic action of taking that information in together, can act in real time on that call, and I wanted to play a demo, just couldn't work it out with the mic here. But if any of you guys have heard that, I mean, there are lifelike now agents. It's just like you and I talking and having a conversation. That agent can take action in that phone call to deploy a script refill, to contact and send a message and alert out to a community health worker or a caseworker. We're able to intervene and move upstream on the population health front to avoid, on this individual level, something that could cost hundreds of thousands of dollars to maintain that individual at home in the community. So, next couple of slides, when we're wrap this up, we're running late on time. The main thing here is that we are, I think, at a transformative place in our healthcare economy. I'm so excited about the rural health transformation dollars and what states are doing, right, with those. And one of the things that our state is doing in other states is this awesome opportunity called the AHEAD model. Check it out. It's kind of in practice. It's a CMMI innovation, a lot of acronyms there. But in theory, in concept, what it does is flip the model from reactive to proactive. Like politics, right? All politics are local. I firmly believe all healthcare is local. And so what the AHEAD model does, and you're going to hear it called the Great Health in Georgia. That's Stuart, our Medicaid director, his acronym of how he is going to fashion the AHEAD model in Georgia. It flips the model from fee-for-service to prospective payment. And it puts a shared risk model in place between policy, payer, and provider, hospital at the core of it. When that happens, we're looking at proactive preventive care that we can put in place if we bring tools and resources to manage that risk on the front end. I'll leave us with this. One of I think the use cases here, I think our speakers already spoke to this a little bit, but the ambient nature of healthcare, we are faced with a workforce crisis with the silver tsunami coming, and the ambient nature of AI and what it offers. Patty, I think, highlighted the transcription services many of you might have been seeing, your physician lately. I thought it was a breath of fresh air when I came in and my doc said, hey, Jason, do you mind if I record this session? I'm like, yeah, what are you doing? Well, he had an AI agent on his phone, and that AI agent transcribed the whole, visit that I had with the doctor. For the first time in 20 years, I had a real authentic interaction with my doctor that really, I think, got to the core of my needs versus seeing the back of somebody typing at a keyboard. So that brings the relationship back to medicine, but it also extends a lot of that workforce, that burnout that we're seeing in a way that we've not been able to cross, in a long, long time, right? Since Dr. Welby long ago. So just leave us with this. I want to, I think we're at a transformative time from a systems perspective, and that's my perspective, right? How do we bring a systems perspective together, the four-legged stool of community, provider, payer, and policy to wrap around the family, the community, move upstream from reactive preventive, and change our ecosystem, right? And keep the bears out of our trash cans. So let's go get it and make it happen, y'all. Yep.
Hi, my name is Kwame Liddell. I'm the founder and CEO of ThriveLink. I'm super excited to be here and share our story and what we do and why. I'm going to give you a few items to leave with. I'm going to tell you, as a leader, how to think about evaluating AI products as you think through strategy, and give you some real examples. My background, I'm an emergency department nurse and a healthcare lawyer. And the reason why we started ThriveLink is because I worked at the county hospital in Oakland, where it was one of the most complex populations in America. There were families who were unhoused, children who needed things, people with mental health disorders, and there was no way at the bedside to actually get them into all these programs that already existed. And it was just disheartening for us to see so many families where I could see on their chart, they've been to the emergency departments. They've tried to go through the system, but now they're in front of us who just had a stroke or is now an amputee because they couldn't afford medications that we could have gotten them. We all seen these stories, and ThriveLink started out as a nonprofit where we're nurses who volunteered to help people do the paperwork, and it's grown into something where we've helped families across the country in 17 states now. And part of my experience before we started the company was I was a leader at the county and at a regional health plan. And there are things that I see now that I've been on both sides of the table that I encourage you all to think about as you evaluate products and you work through your strategy. The first thing I want to introduce you to is the concept of tokens. So essentially, when you have a conversation with the AI agent or you maybe write a paragraph in ChatGPT, the way that it's charged is through tokens. So in 2023, for 125 words, which is like half a paragraph, it was a penny. Now it's drawn down to where you can do 3 pages for a penny. Now the important thing about that is that there's no policy around this. This is just the 3 major companies competing with one another. So so as you think about evaluating products, you should ask the question of their token utilization, because that price will change. This is as cheap as tokens will ever be. So if the prices change for tokens, kind of like oil, you will have to pay the price later. So it's something to evaluate and make sure that you put in your contracts. Also think about integration. Workflows, in an AI world, workflows are more important than the actual integration. Thinking about where can technology actually change and benefit your providers, your social workers, your call centers, et cetera. Finally, outcomes. I think this is a place where I think people are beginning to open up and take risks. And I think that if you start small, it's safe to try things. I think that our infrastructure and our security teams understand how to make those evaluations safe. And because of the outsized outcomes that are available to you, I encourage you to try things. Even if you have 100 hospitals, start at 1. Start at 1 department at 1, because you will be able to see the system quickly and expand it and really benefit from the ROI. So I'll talk about these concepts in a real life example. Here's one where this is Advocate Health, which is a part of the Atrium Health System that you see here in Georgia. And this is in the North Carolina market, where you see an actual relationship between using an AI product in a clinical space and it communicating with the government agency. So in this space, they screen patients for SEOH needs. And this patient was housing insecure because she was behind on her utilities. So she shared that she was not going to be able to miss work to go to her next visit. So by simply having a conversation, and we saw here that she called after 11 p.m. So she had this conversation after 11 p.m. If you think about the ecosystem today, the Georgia general government agencies that would support, they close at 5 o'clock. Community organizations close at 5 o'clock. Doctor's offices, et cetera. When you think about where you can insert AI, you see an example where now this turned into a 24/7 operation and paid her $519 utility bill. The second piece that we think about prioritizing tokens, think about it in such a way that you use it in a space where it actually matters. So making sure that it works in 75 languages, it's available 24/7, there's no reading, and all those options. So really a benefit that never existed before was to think about how can you create a new experience. Today, a person has to I have to be tech savvy enough to go on a website, or I have to go miss work and go meet with someone. But now there's an in-between, there's a gray area. And we're talking about social services in this example, but you can think about that for mental health visits. You can think about that for different follow-ups. I think there were some examples around medication refills, prior authorizations, et cetera. Really think about what's that gray space that's available to you. And in our example, in our use case, the way that we do that we think about outcomes are really important, whether it's financial ROI or quality outcomes, et cetera. So it's 60 to 80% cheaper than FTEs. So when you think about, hey, we have this problem, and right now, in our case, we do paperwork to help people navigate through these services. But you can think about it in other places where the option now is to hire 100 more people. Well, maybe there's a way to augment that by helping a percentage, even if it's 50% of the population that now has to go talk to people, navigate into other things. And we did a study last year where we said, what is the actual outcomes? So when people answer all the questions, what happens? 96% of them actually receive services. So if they signed up for Medicaid, they got an outcome. If they looked for medication, it got delivered, et cetera. So the three areas that I encourage you guys to think about as you're evaluating it and taking these risks and bringing on these new products is tokens. I've never seen one in AI committee. I've never seen that question. And also when you think about contracting, definitely your AI committee, think about tokens. The second piece, integrations, really focus on how it impacts your workflow. I would start there, then work backwards into actually connected to the system. And finally, outcomes. Don't compromise. Whatever outcome that you actually need, focus on that and make that the driving factor. Thank you.
John is in the enviable position of having to do his spiel in 5 minutes, but I'm sure he can. Go ahead.
Yeah, thanks, Mondo. So this panel is like a microcosm of life in the AI era, right? Huge amount of information, super interesting, coming at you really, really fast, and you have to figure out kind of what to do with it, which is the current state of affairs in health research, where we're seeing a huge amount of data being generated all the time. And so what I'm going to talk about a little bit, I'll take a break from the words for a sec. What I'm going to talk about a little bit is how researchers are developing techniques to be able to handle the immense amount of new knowledge, literature that's being generated, how to conduct studies, and how to utilize AI, which I think in some ways there are certain advantages, right? Not being in an operational setting or a clinical setting, researchers sort of have the ability to poke a little further down into what can be done without worrying about some of the constraints that I think are in place. But it also leads to a lot of challenges as well. So I'm gonna skip the words here and just go to kind of what things are we seeing in health research, and in particular using health data, right? claims data, EHR data, other sources that drive a lot of the healthcare research. So I'm going to talk a little bit about these three categories. So AI that just sort of improves productivity, AI that enhances health data themselves, and then AI that sort of supports health data analytics, right? Kind of doing things downstream. Provide a few examples and hopefully make the time to keep on track. So one thing is about discovery in the literature. This is a great resource. So this is called ASTA. It's from the Allen AI Institute. If anyone has used PubMed or Google Scholar, you've searched for the literature, you're familiar with it. What this does is it lets you have a really good natural language conversation, and it brings back sort of based on relevance in the different categories and subcategories of what you're looking at, you can really get a very nuanced discovery around the literature, which is absolutely essential now because it's stacking up fast. Another piece is actually around reading and reviewing the papers for their quality. I don't know how many here have been exposed or used what's called skills in like Claude or Claude Code or any of these things, but it's kind of this idea of computer readable knowledge in ways of conducting all kinds of affairs. If anyone's been tracking the SaaS apocalypse where all of the software companies took a huge dive, it came from this issue of skills, which is to say that you can package your knowledge and then put it into an AI so someone can use your approach to doing something and it kind of automates that. And so the fear is that people will be able to build that to create their own version of TurboTax or their own version of a CRM or whatever, and all the companies dive. But by the same token, there are tools that really help you, for example, go through the literature. This is from the skills marketplace. There's 860,000 skills. And here, one is for analyzing the literature. It's fantastic. It's better than I think most researchers would do. One is around drafting papers. I know people are thinking, oh my gosh, AI-generated papers, that's the last thing we need. Well, that was like a 2023 and 2024 kind of thought that they're going to just be crummy because they're AI, drafted. I think what you see is that the new tools enable us to really go through in a much more rigorous way than a researcher could do independently to produce a backbone that they can then build from that is very, very high quality. Another domain relates to enhancing health data. This is a requisite AI-generated image. If you see an image like this, you should be thinking to yourself, this is clearly AI-generated. We won't talk about all the reasons, but suffice to say what the story here is, health data are fragmented. There's unstructured like images and text and video, and then what we need to move them into is an AI-ready form. So we're using and adopting AI to take things like claims and EHR and all other sources, but putting them into a format that is very easy for AI to then process efficiently and to use for analyses. So that's a widely adopted and increasingly adopted area. And then the last area is around data analytics itself, everything from natural language querying. So instead of using things like database CQL or SQL code or Python, of course you can just do natural language queries and it goes underneath the hood. You can do natural language queries to look at visualization. This is us looking at data in terms of access to care in Georgia and coverage of different providers. Your conversations are now natural. We've all used dashboards for years. People were like, I want a dashboard on this, I want a dashboard on that. But I think we're moving towards, you just want to have a conversation about it, and where a dashboard is appropriate, bring it in. Where there's an optimization or a simulation, bring it in. But it's really more conversational. Cohort and registry generation, looking through the chart, pulling out relevant patient data, putting that together to answer those questions. These are high FTE roles, as people know, also looking, for example, for financial reasons, for Medicare reimbursements. This has been very, very heavily moved towards AI-based capabilities. Augmenting researcher skills. I have a mental block about biostatistics. I can never remember, do I do a t-test or which biostats test should I run for a given problem? I don't know why I have that. But these skills allow me not only to do my own stuff more efficiently, but to be able to say, I'm going to, instead of calling my biostatistician friend right away, I'm going to go through this process and I'm going to extend my own skills. And then if I need to check in with them to kind of clean it up, I'll do that. But the extension of researcher skills into areas that they didn't do before, that's a really big, big contribution. So what are the barriers to adoption? Number one, AI slop. That's the general term for like just junk that's generated by AI. There's reality to that. I think we've all seen it. But there's also AI slop, the perception, which is that people think an AI-generated paper or whatever will be garbage. And I think where we need to find is the reality is definitely in between. Things get, whatever AI we're using today is the worst AI we'll ever be using. It keeps getting better. The pace of innovation is really, really fast. So it requires a very adaptive mindset. The funding environment, of course, always kind of challenging. And then there's the researcher or the ecosystem level comfort with more AI involved. Is this an AI augmented research? Is this AI driven research? Or is this like AGI, which is that like artificial generalized intelligence, where the AI is doing the whole thing and is iterating, right? And so people may say, I'm comfortable with AI helping me, but if it can just do the whole thing, what is my role? And how do we overcome these? I think adaptive mindsets and skill sets, really entrenched beliefs about AI, good or bad, should be avoided. They're constantly moving. And then sort of the responsible uses of AI should be clearly defined and updated by leadership in research like NIH, NSF, and so forth. I was pretty close.
Yes.
All right. Thank you.
Thanks to all of the panelists. And I believe we are out of time, aren't we? Okay. Can I ask one question of the panelists? Okay. Oh, that's good. I'm not going to try to bring the bear trap into the conversation here. What I'm going to do is ask folks, all of them, one question real quick. What is the one AI use case that they are really super duper passionate about? If you already spoke to it during your presentation, fine, but it gives you one more shot at talking about it. Jeff, please. Got to press.
Am I on? Yeah. Since I do kind of fundamental research, the AI use case is simulating virtual cells. Because at the end of the day, we want to understand how these things work for you. And it's kind of a swarm. I mean, you have 20,000 different proteins. There's millions of molecules. AI is particularly well tuned to deal with very large data sets and network information and collective behavior. And so in collaboration with Dave Gordon and his team, who's keeping us honest because he's a real experimentalist, we're actually building a virtual T cell, which we hope can actually inform diagnosis for individual patients in the very near future. And it'll be like an onion. You do round one, round two. That's where I think the most power of AI is, which then ultimately, hopefully, will translate into clinical relevance quickly.
Excellent. Thank you. Patty?
Yeah, I'm going to have to talk about an AI product of a company that's in the room. Vendeca Health is one that I've gotten really excited about, and it's really because it has a patient outcomes ROI and a financial ROI. And it's a pharmacy, medical, or medication use intelligence product that does the work of the P&T committee, which is the committee that looks at all the medications and approves what goes on formulary, and what the pharmacists currently do in several days, weeks, months even. This product can do in minutes, and it can be proactive, it can be reactive, and it presents opportunities to reduce cost and to improve patient outcomes.
Excellent. And I can see the connection between Jeff's use case and Vendeca, so it's very cool. Jason?
So who knew Bear Box and AI would come together? But here we are. The thing I'm most excited about, y'all, is the transformative nature of the marriage of disparate data sources. I'm an old decision support BI, business intelligence guy. So how do we connect all these disparate data sources to create a unified record to get upfront, upstream, to flip the trend, bend the trend, turn the curve, to avoid those acute catastrophic events, keep families together, communities healthy, and people safe. So I think AI has the ability to do that. We've got the data there. We've got to connect the pipes. So I'm pretty pumped about that, and I'm excited about the future.
All right, thank you. Kwame?
Question for the audience. How many people here know how to, right now, get a blood pressure cuff for a wheelchair through your insurance if you needed to? So maybe less than 10% of the room. And we are well informed in this space. We understand. But think about how it is for the common person that's in our hospitals, at our social service agencies right now. So the real thing, and that's what we work on, is making a system more accessible so that we leverage AI where people can just have that one-stop interaction and access all of these things that would even be beneficial to us in this room.
Excellent. And then John.
Thank you. So, from my perspective, access to care is the biggest one that I feel strongly about. Provider overseen AIs to be able to enable access to care around the clock. The idea that someone can't get their asthma medications refilled, have to go to the emergency room to do this, that should not happen anymore. In Utah, they've actually passed a law where AIs can prescribe medications. That may seem extremely frightening, but if you think about it, just how do we solve to make it less frightening, right? How do we solve to say, what is the oversight? And I think we can do that, so we are in a world where people can get care anytime people have not been able to access, or just the difficulty of leaving work to get somewhere to be seen is no longer an issue. And so for me, access is the big one.
Thank you. Quick closing thought, because I won't be here this afternoon because I got a flight to the tropics. What a horrible life I lead. But I will say this. You should all look at AI not as technology, but as a resource, an asset that can be deployed in so many incredible ways, like all the panelists shared, to truly transform the way that healthcare is delivered. So reach out to them during the course of the day. I'm sure they'll love to talk to you. And thank you for your time. This was a dense topic to kick off an event like this, especially at 8:15 in the morning, but I hope that you got a lot out of it. So thank you very much. Gracias a todos.